Good job being here. How's everybody? Tired? Tired. Tired? Yeah. I feel ya. But we got exciting stuff to talk about today. Okay, so in the Father, Son, and Holy Spirit, amen. Oh, thank you for this day. It was a beautiful sunrise. So thank you for that. Thank you for those little gifts, and it's gonna be a beautiful sunny day. Thank you for that. Help us as we're feeling tired, maybe. Not a lot of motivation. Just help us push through and just work hard, help one another learn all this stuff well. Thank you for all your many gifts, healthy bodies, minds, and spirits. And just pray for all those who are often forgotten or who have no one to pray for them. Let's pray for anyone who is feeling alone or have a lot of people around them to support them. We pray for anyone who's sick or suffering. From comfort to hands of caring for them. Amen. All right, my friends, let's talk about an exam that you just took. Good job. Well done. We'll post them today. I will. I'm willing myself to get it done today. So let's talk about an exam review. No, we don't usually do that till after I post, but I would like to do it this Friday if possible. That works for everyone. Same kind of sitch as last time, noon-ish. Okay, next. Show me your hands if you can make it between 12 and 1 on Friday. Okay, that's some. All right, that's the majority, I think. But if that doesn't work, email me and we can set up another time to do it. So I'll just send out the little Google Doc, same thing. The average is good. It's 85, which is what it's been the last, I don't know, 4 years or something like that. So that's good. So I will get those posted and I will send you the little email when I post it. Check it. Anything else I should be thinking about? Lab, learning EKG strips. Our favorite week. This is it. I'm telling everybody yesterday, I'm like, I know you look forward to IVs, which are fun. That's legit. But this is so satisfying. It's so satisfying for me to be like, this is how you do it. There's no more like mystery. Like cardiology, here I come. But every one of your patients on monitor will benefit from you knowing this information. So that's good. Okay. And what we're talking about today, so common. You are going to see cardiovascular conditions in your patients because it's the #1 killer in America. So you will see this. Anything else? Things coming up next week. GI, my lands. GI, lots of awesome conditions in our intestinal tract. We learn NGs next week. Ostomy care. TPN. Enteral feedings. So yeah, it's a big lab next week. And then we got blood. And then that's it. Oh, here we go. How much more times do we have left? A month? Maybe a little more. We got a little more than that. Right? What is today? I don't even know. You check my orientation right now. I know where I am. I know who I am, but I do not know the date. What is the date? 26th. Okay. About a month and a week. We can do it. We can do it. Let's do it. All right. Can you see this? Yes. All right, let's talk about cardiovascular conditions. There's a lot of them. So let me show you which ones I want you to know. Can you see that? Okay, so we're gonna talk about CAD, CHF, hypertension, peripheral vascular disease, including PAD, carotid artery disease, deep vein thrombosis. We already know a lot about that, but and then valve disorders. Okay, so that's my goal. I do have a little quiz for you, but I don't know if we'll make it to that. If we don't make it, I will open it up for you to complete before Monday. Okay? Odd, but that might be how it happens. Let's go. Here's a little case study. Can someone read that? Jessica, can you read that for me?
Randy is a 48-year-old Caucasian male who presents to the PCP with recent complaints of chest pain. The nurse further assesses Randy's complaint of chest pain to find that there is sharp intermittent pain occurring in the middle of the chest. The pain primarily occurs when he is exerting himself, lasting only a few minutes and resolves after rest.
Okay, so if you're highlighting this, or you're thinking to yourself, what stands out to me in this little case? What would you say? Yeah.
That it occurs when he's exerting himself.
Yes, we got chest pain upon exertion. That's it. Critical information. Why are we saying that? Good, awesome. So what are my two different types of angina? Or angina people, call it, don't say, okay.
Stable and stable.
Yeah, stable versus unstable. So what is this? It's happening when he's exerting himself. Stable. Okay. So this is not good, but as not as bad as this. Okay, so when we're actively like doing something, like exercising, or if we're under stress, we start feeling that chest pain. We call that stable. Usually, if they stop doing whatever they're doing and rest, it goes away on its own. That's awesome. Unstable is they're just sitting there. They might be sitting in the chair, reading the book, not taxing their heart at all. And they're feeling chest pain. That's obviously a worse sign, right? Like we're not even stressing the heart and we're having symptoms. This doesn't go away because it's just happening even at rest. So what do? You're going to educate your patient to do. Ignore it, sir. No, people, time. Time is life, time is muscle. Strokes, we say time is brain. You need to take action. What should we be doing? Randy, our 48-year-old, young. This be happening. I want to know about his past medical history. What are we gonna do? People in the lab yesterday. Yeah.
Nitro?
Nitro, awesome. So how are they gonna take that?
Once you go to the same way, 3,000 minutes, I'll take that sometimes.
You 5 minutes. As you having pain. Until it's 0. 0 out of 10. Times 3. Good job. 1 tablet, sublingual, Q5. As pain persists. 4. They've taken 3. Okay, awesome. Nitro, what's this? Nitroglycerin. You feeling like nitroglycerin? Okay. So let's say I do that. I'm Randy. I have taken that. I'm still having it. So I take some more. And then I take some more. Should I hop in my little vehicle and drive myself to the hospital? Why?
It needs to like drowse me out of it, so you need someone else to do it.
Yeah, not just, yeah, drowsy because we may start with a blood pressure of like 165/90. After your first nitro, it could be like 132/70. Then take another one, and we're gonna be down to 110 over whatever. And 60 something. If I take another one. Should I be driving myself to the hospital if my blood pressure is 80? Does this happen? Yes, I can count on more fingers than I have. How many people have told me they have driven themselves to the hospital after taking their nitroglycerin or while they're having substernal chest pain? Do we want someone on the road who is having an MI? It's not safe for them and it's not safe for any of us driving alongside them. So we have to educate that someone else has to drive you or call 911. Once you're getting to your second one and it isn't resolved, call 911. And get help on the way. Okay, all right. Good deal. I need you to know stable versus unstable, nitro, how to educate, what to watch. Moving right along. This is an image from your book. Can you seem familiar? Or my lecture, I don't know. Atherosclerosis image. So this is the normal artery. Nice and clear. This is mild atherosclerosis, and this is severe. So how does this happen? This is on the inside of your layers of vessels. Remember, there's 3 layers. Intima, that's the middle one. Median, and then external. Recall, AMP recall. Okay, so we have a little something happen on the intima lining, the endothelium. There's some sort of injury. We don't really know what that is, but it could be just like microvascular changes. When we're talking about diabetes, we're talking about microvascular changes. Some sort of like injury to that endothelial lining allows what to enter? What is this? Plaques made up of LDL, right? Like lipoproteins, low density lipoproteins. So it will just continue to accumulate. You know, you have a lot, and then it may rupture. So this will open up. When that happens, our inflammatory response comes into play. And so then we have a little platform there, which reduces blood flow even more. And if it continues to grow and accumulate, you can have full occlusion. Okay, so when we're feeling this, that's what's happening. We're at a severe occlusion. This may be moderate. Okay, so we still have passageway, but this may not. Ready? Okay, so CAD, if you had to define it, what is it? What does it stand for? We'll start there. Yes, coronary artery disease, is it a big deal? It's a big deal, right? Who does it affect? Everyone, but particularly males. More male die from heart attacks than females. Except when you reach a certain age.
Most commonly white older.
White older man and Hispanic as well, right? All right, double check that. Okay, postmenopausal women, people with diabetes, people with hypertension, people with family history. So if someone tells you that their grandmother died from an MI at age 56, and that their father died when he was 62, I would be like, white on rice on what is happening with that person. Because there's a family history. I'd want to look at their blood levels, cholesterol levels, LDL, HDL, I would wanna look at lifestyle, I would wanna look at exercise. Because some of these things are modifiable, but that family history is not. That is a toughie. Right? Yes. Yes, I told my Tuesday people, my dad had lots of cardiac issues happening. And it's, I think, I mean, a lot of it was, like stress, that kind of stuff, but genetics. So my brother, the youngest of five, my oldest brother, he's like a fiend, working out fiend. Me, not so much, him, working out all the time, eats pretty good. Me, I love my chips. His cholesterol, high, and it hurts him that he has to take a statin. He's like, I'm doing everything right. I'm modifying everything I can. I have never smoked. I exercise every day. And still he has to take a statin. Right? I should get my check. Let's stop there. Okay. Okay, so risk factors, we talked about that, signs and symptoms. So these are signs and symptoms. Anything else that we might see when someone has CAD? So this is angina, this is the pain that's associated with ischemia or that reduced blood flow to that area. But what other signs and symptoms might they say? It's not, this is what leads to an MI. So that substernal chest pressure, pain radiates down the left arm into the jaw. That's like classic. But there's other symptoms too that maybe are not as known. Yeah, thank you.
Vomiting and fatigue.
Yeah, nausea, vomiting, fatigue, particularly for which group? Women. So this is what happens. Women think it's something they ate, like that they just have GI upset. So they go like lay down, be like, I just don't feel so good. I feel like I ate something wrong. I'm just gonna go lay down. We don't wanna do that. Like it could have been something to eat, but it could not be, and we wanna err on the side of caution if it's your heart. Right, so we have to know, like, it may not present with that kind of pain, pressure. Right, so nausea, GI upset, kind of reflux. In fact, we give Maalox to people when they come into the ED to distinguish if it's that or if it's cardiac. But we're always moving towards cardiac because that's the worst case scenario, right? But we give the Maalox just to see if that will help if it's GERD. Okay. What about people with diabetes? How do they present?
Same as women.
Can be similar or no symptoms. Maybe fatigue, shortness of breath as we get older. They may say, like, when they're out, that was my dad, he was out walking their dog and he didn't really have pain, he didn't have pressure, but he had shortness of breath. So he mentioned that to his doctor and his doctor was like, okay, let's do a cardiac cath. And we found like 3 blood. One was able to be stented, the other one wasn't. But then he had bypass surgery. 10 years later, he had bypass surgery again. So knowing that it just doesn't end, even though we did major lifestyle changes, still didn't change 100%. Okay, so just know symptoms can be variable depending on who we're talking to. I want you to know like some of those vague symptoms, nausea, shortness. Okay, modifiable factors. I mentioned some of those. What are the things that we can change? Or brother? Smoking. Activity level. Alcohol use. Reduction, right together. What we eat. And then controlling hypertension. Maintaining glucose if you have diabetes. Non-modifiable. History. Right. Meds. There is a slew of meds for CAD. So I want you to look at them. I'm not sure what page they are on. Nitro for sure. Find the page number. What other meds do we use? Nitro?
Beta blockers.
Awesome, beta blockers, such as. Anything that ends with an all, metoprolol. Phenol. Got it, good job. That reduces oxygen demand. You should know, what is one of the things from pharm that you learned about beta blockers that we should tell our patients? The do.
Does it have orthostatic tension, should monitor and get up slowly?
Yeah, getting up slowly. Anytime we're on antihypertensive, right, we're gonna dangle before we rise. Yeah, good. It also affects,
Doesn't that affect the beta receptors in your lungs, so if you have asthma or something?
yeah, we can see that in ACE inhibitors as well. That's where we get that cough. This one, remember, it reduces heart rate. So my other brother, who's a firefighter, is on beta blockers because he's the one with diabetes, right? So he's got two double whammies. He's got the genetic history and he's got diabetes. That puts him at risk for CAD. He has already had his first cabbage, right? He's in his 50s. But he has to stay active. He's on a beta blocker. So he like runs, but his heart rate never gets up. So he never feels like he's really getting a good workout in because it suppresses that. So that heart rate is going to be reduced. So we should be checking heart rate before we give beta blockers. We should check it before we give DIG, but just know like that's a weird thing for people who are on it, that they don't really feel like their heart rate ever rises. And that's intentional. We don't want that because it stresses the heart. But for him, who's trying to feel like, am I getting a good enough workout? He doesn't ever feel it. So, beta blockers, good. What else? Statins. Statin, anything with that statin at the end. It's for cholesterol, right? Good. Keep going. Yeah. Good. Our little ACEs. Birds. And then converting enzyme inhibitor. Stopping that RAS system. And what do we have to watch out for that? Cough. That dry hacky cough, you will hear that. If someone has a history of CAD, you walk into the room to assess them and they're just like. Like these cry, like there's nothing there. You're gonna be like looking on their med list and be like, how long have you been on an ACE inhibitor? They're like, I just started it. Why? You're like, I think we might need to change it. It's very, very common. Nitro, you have to take that, Nitro comes in like a little brown bottle. It's sensitive to sunlight, so you can't have it out like on your counter. It has to be in that little darkened bottle. You want to watch the expiration date on that. They should carry it with them wherever they go, especially if they have unstable angina. Okay, what about aspirin? No antiplatelets beyond that. Maybe another antihypertensive. Here we go. Which of the following are modifiable risk factors for coronary artery disease? That's a lot. We talk about it and then we yay, tobacco use, yay or nay? Yay. Elevated lipid levels. Food, I guess. Physical inactivity. Family history of CAD. No. Diabetes. We're like, okay, we're talking diabetes type 1, diabetes type 2. Diabetes type 1, you don't really what you can do about that. Type 2, hopefully you want to prevent that. Okay, so I would be more clear with that one. Age. No. Obesity. Yeah. Try to modify that. Okay, turn to the person next to you, explain the top 5 medications for a patient experiencing chest pain.
It's a red blood cell, for the blocker, and so the heart rate, and showing more things for them. Did you get the?
All right, so this is very common when someone comes into the ED or in your ICU. They're experiencing chest pain. We remember this acronym, MONA B. So M is for morphine. We always start with nitro first. If that doesn't subside the pain, we will go to morphine. And then we're gonna put oxygen on, but this one has changed. I was telling the people yesterday in lab that we used to just throw them on 100% non-rebreather, thinking like that's what they need is oxygen. You know, we need oxygen to the tissues, but it actually would cause vasoconstriction, the exact opposite of what we wanted. So with oxygen, we are gonna put it on, but you're gonna start low. So maybe just a couple liters nasal cannula. Only if their SAT is less than 93. So that's a little bit different than what you've done in the past, but you will know no difference. This is what you will know. And then A is for aspirin for antiplatelet effect. And then our little beta blocker here. All right. So once we've done that, we're getting EKGs, we're cycling through that. We want to get it down to 0, but let's say it doesn't get down to 0. What will we go to next? Cath lab is coming, right? We're gonna be wheeling them out before we get there because maybe there's someone that they're working on in there. What are we gonna start? A nitro grit. Nitroglycerin usually used to come in like a bottle, like a glass bottle, so it's very distinctive. Let's say there's 100 milligrams in 250. Nitroglycerin is ordered mics per minute. Okay, so let's say they want you to start it at 5 mics per minute. 90 now. Figure out how many mLs per hour you are going to set that for. Okay, take note, this is in milligrams, so I need to convert that to micrograms. What would that be in micrograms? Yeah. Throw it out there, Daniel, it's okay. 100,000? That's all right, okay? You with me? Okay. All right, so why did I do that? Because my order is in mics. I need it to match. Okay, so I can't, I mean, I could put the conversion here, I can write that out, but that helps do that, right? Okay, so what's 5 times 60 times 250 divided by that 100,000? I don't know the answer, so yeah. What we got?
0.75.
0.75. Okay. So it's set on the pump 0.8 mLs per hour. That would be running at 5 mics per minute. Nitroglycerin, you would increase that by 5 mics until they had no pain. Okay, but you have to watch their blood pressure. Okay, so that's from your lab ticket. There was mics per minute and mics per kg per minute. So we'll talk about that one in a sec. Okay, awesome. So Randy sent to the cardiac cath lab where he undergoes a percutaneous transluminal coronary angioplasty. You understand why we have acronyms. PTCA, or stent placement in the right coronary artery. What will you do following this procedure? Okay, so what is this procedure? I am anxious to find out. Let's see. On AHA. Let's look back. That's the blockage. Is it 100% blocked? There's good blood flow here. White here. Not what we want to see. Oh, good blood flow here. So this is where we want to put a little stent. But first we have to explore the library. Okay, cardiac cath. Stent. All right, so we first go in with this balloon and it just like smoshes everything up against the lining. So it opens it up. And then go back in, same little thing, and put a stent, like a little piece of fence. Boop, to hold her open. It's like chicken wire, but very little. Okay, let's see if it shows us that. So they're going in the femoral artery. Goes up here, blue, 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 blue. And they're gonna shoot dye. That's what this image is. Yeah, it's in the coronary vessels. They're gonna shoot dye. Okay, there's what we're looking for. Oh my gosh, that's where the blockage is. Right? That's what it looks like. There's the plaque, reduce blood flow. Put a little guide wire through there. Smoshy smosh with the balloon. Retract that, wire still there. And then we put in the stent. Okay, that's PTCA with stent placement. So what kind of things are you going to be watching for when your patient comes back from that? Let's back up. What are the things you're going to ask about before your patient goes? Do they shoot contrast dye into their vessels? I want to know if they have an allergy to that. I also want to know their kidney function because I'm going to shoot dye that's going to get to their kidneys. So let's check your BUN and creatinine. And then when they come back, I have entered the femoral artery. Yeah.
Is it a monitor for bleeding?
Yes, right at that site, right? Because if it opens up, you got about 5 minutes to stop it. Remember? That's the one where if it opens up, you're like standing there with full force. Like if you do a handstand on their leg, you would. Full body weight or a 10-pound weight if you have it available for you. In the cath lab, they have that. They also have clamps that they will clamp down on their, like, you know, construction, like a C-clamp. Pressing down on that artery because bleeding is such a big issue. Yeah. So checking for bleeding, I would be checking for pulses distally. So I'm going to make sure that they still have pulses afterwards because what if they perforate the femoral artery? Do you have perfusion going to the lower half of your body? No, that's a problem. So I would be checking for pulses, I would be checking the site for bleeding. Remember the story I told you guys about the person who had retroperitoneal bleeding? So if they're complaining of back pain after they've had one of these, I would be like, I see their blood pressure trending down and their heart rate trending up. And they're like, I feel like something really bad's gonna happen. What do we call that? When your patient says impending doom, they're not gonna say, I'm experiencing impending doom. They don't say that. They say like, I feel like something very bad is gonna happen. And you're like, okay, and you just start assessing, because something is going to happen. If your patient is feeling that, it's a real thing. You should make little hairs on the back of your neck stand up because you're like, holy crumb, something is gonna go down here and I'm responsible. So you just start assessing like crazy until you find what the issue is. And it's usually a big thing that's happening. Not like, I don't know, a hangnail. It's not that. It's like we are going down. Okay, so start assessing like crazy, get those vital signs, start taking them again. Think of all the complications that can happen. Bleeding would be the number one for this one. So get on it. Okay, don't be lackadaisical about checking that site. It's like every 15 minutes, you're checking site, checking pulses. Okay, they have to lie flat. They can't have their head up, so they're in a reverse Trendelenburg. They're just like hanging out like this for 6 hours, 8 hours. They do complain of back pain because they can't move. So you have to distinguish, is that something different? Where is that pain? Do I see a big old hematoma forming here? Am I feeling no pulses? Are your feet cold? Is that a change? And then urine output. How much urine output are they having? Are their kidneys not perfusing well? Seeing that decline in urine output? Are they cold and clammy and pale? So all your assessment. Okay? Ready? Back to business. All right, what we do following this procedure, monitor site for bleeding or hematoma, yes. Monitor for changes in vital signs, yes. Restrict fluid. No, we gave them contrast dye, you gotta help those kidneys, so we give them fluid. If they can't drink lying flat, we give them IV fluids to help flush it out. Assist patient to a high Fowler's position in 1 hour. No, if you use the radial artery, yes, you don't have those same restrictions as a femoral approach, so just know that. But this was a femoral approach, so no, educate patient to notify you if he experiences any chest pain. Yes, what would that mean? That the little stent that you just put in, clotted off. That's a bad sign. This person's probably gonna go for a bypass surgery then, right? But in the meantime, we gotta get them there. So let us know if they have chest pain and then monitor fetal pulses and temperature of the extremity. Yes. Okay. CADP is MI treatment, MONA, antiplatelet, anticoagulation stents, PTA stent, bypass. Okay, so what is your understanding of a bypass surgery? We just talked stent. What's bypass?
They take a different vessel and like graft it over the blockage, so instead of like it running straight through, you kind of connect up here, connect below, the blood can go around.
Right, good job. So we're talking about our coronary vessels, right? Just like that image showed, if there was a blockage there, right? So there isn't blood flow getting through, there's the blockage. So we're gonna take a vessel, usually one from the lower legs, maybe the like saphenous vein. We'll take that, we'll hook it into the aorta up here and just bypass this to perfuse this section. Because right now, no blood flow getting to this whole portion of the heart. Yikes. We have cell death here. We're gonna have CHF at minimum, death at the worst. Okay, so bypassing that area to perfuse is really essential. Okay. After someone has bypass surgery, what are things we have to educate them on? This is major surgery generally, if they get a little bit less invasive, But just traditional, they are sawing through your sternum and opening up your chest. And sometimes you're on a heart pump machine, so that's doing the circulating for you, and the surgeons can just hold your little heart in their hands and sew up a little vessel. Or very seasoned, experienced, hopefully cardiac surgeons can do that while your heart is pumping. But I just want you to think about what that looks like. You're hooking into the aorta, bypassing it as the heart is pumping. So this is high risk surgery. So coming out of it, external precautions, they're gonna need to be able to splint, because we actually have them cough, deep breathe to prevent pneumonias from setting in, you know, all the surgical stuff we need to help them with. And then they can't drive because they were in an accident and were hit into the sternum. Good. Okay, all of them. So taking those kind of precautions, and then all the lifestyle, diet modifications, they'll go into cardiac rehab hopefully after that. Okay. All right. Now we talked about that. Which of the following blood tests is most indicative of cardiac damage? So I want you to answer this. Troponin I, complete blood count, creatinine kinase, lactate dehydrogenase. Yes. Troponin, right? I want you to remember our cardiac markers are troponin, and there's troponin I and troponin T. I won't really ask you that. I just want you to hone in on troponin. That's a specific enzyme that is released when we have cardiac damage. And then CKMB is specific to the heart muscle as well. This one starts about 3 hours after injury. We'll see it elevate. Lasts for, is it 48 hours? 36. Thank you, gold star, 36 hours. And then troponin doesn't really start elevating until maybe 4 to 6 hours after injury, but stays for 10 days. This is how we know someone has had an MI like a week ago. Maybe they didn't come in when they were having those symptoms, maybe they weren't having symptoms, but then they come in and we can check their cardiac markers and see like, oh my gosh, your troponin is elevated. You had check. People are like, what? Like, that's how we know. Take them to cardiac cath to see where the blockage is. Okay. I think on page 589, is that the one that has all the lab values? I want you to know those, like LDL, HDLs, this. You'll see something that's called CK. That's just a generalized enzyme that we see with inflammation, but CKMB is what I want you to hone in on. And sublingual nitro. I think we talked about that. Miss Izzy told us how to take that. Primary reason for administering morphine to a client with an MI. To sedate the client, no. To decrease the client's pain, yes. To decrease the client's anxiety, well, to decrease oxygen line. Okay, that's really why we give it, but it will reduce pain. So, okay, so I would say D. What is the most common complication of an MI? What do you think? Cardiogenic shock, that can happen. Heart failure, yes. Arrhythmias, yes. Pericarditis. C, arrhythmias. So tell me, why would that be? Why would we have arrhythmias happening after an MRI? Good job, good job. It's gonna say, like, think back to the conduction system. So if we have a vessel that's perfusing my right atrium, like the right coronary artery. And there's a blockage there, and I have cell death occur right in that spot. Maybe my SA node will not be able to fire anymore. Maybe my AV node will not be able to receive or transmit that impulse anymore. Or maybe my little atrium itself cannot function. Okay, so arrhythmias is a big deal. All these other things can happen as well, but arrhythmia should be right on the top of your like, oh my gosh, I gotta be watching for this. My patient just had an MI within the first 24 hours. They can have deadly arrhythmias. Okay, so have them on monitor, watching for that. Okay, pericarditis. Did you read about this? This is actually what you learn next year. So I don't think I asked you about it. It's interesting, so we're gonna pass over it. Okay. Congestive heart. I need you to know this. So what is this? You're probably taking care of patients with CHF. What is it? Yeah, to put it in a nutshell.
Heart's inability to meet the body's needs.
Right, exactly. The heart's inability to meet the body's needs. That might be me sitting in a chair, that might be me exercising, but the heart cannot meet whatever need is placed on it. How can that happen? MIs. If our cells are dead, can they contract? No. If I have hypertension and it causes my left ventricle to get wide and kind of floppy and not be able to contract well, that's another reason we could have CHF. So there's different underlying kind of causes for it, but it's basically the heart can't pump to meet the body's needs. But I know you know all the symptoms because we talk about CHF a lot. What kind of signs will you see with a right-sided heart failure? So the right side, the right atrium and the right ventricle can't pump, so everything's gonna kind of back up where? JVD, so into the body, right? Yeah. So right-sided, we have JVD. Good, keep going. Edema, good. Keep hitting edema. 4 plus, 3 plus, 2 plus, 1 plus, trace. Yeah, so that's in the extremities. We see that. You can actually see it other places too. And the sarca can be all over. Anything else?
Acromegaly and ascites.
Yeah, good. Ascites, that's that inflammation of fluid around our abdomen. Splenomegaly, yeah, good. Splenomegaly. Like that, splenomegaly. We just have a lot of fluid accumulation in the body. Okay? Left side will be my left ventricle is not able to pump blood out to the body. Where am I going to see or hear or what?
Shortness of breath.
Shortness of breath because, yeah. Pulmonary edema, oh my gosh. You know what this is? Like flash pulmonary edema. Have you ever seen this? This is. Gosh. Okay, so this can happen when we have so much fluid. I think we call it flash because it can happen like this. The classic sign of this is pink, frothy sputum. Why pink? Because you can have all these little capillaries that are kind of distended because all this fluid. So you actually have blood, that's what you're seeing. And it's like frothy, it's like you took your, I don't know, someone who works in a coffee shop, the little foam, whatever, the little, whatever that is, turn it pink and have it coming out of someone's mouth. That's what pink frothy sputum is, and that's a sign of pulmonary edema. They are drowning. They are drowning from the inside. So this serious business. What do we do for that? Diuretics, people, you gotta get off the fluid, get the fluid off. And put oxygen on for sure, and then diuretics. Okay, so that doesn't always happen with left-sided failure, but that is a definite bad complication of it. What are you going to hear when you're listening to people who have left-sided heart failure? Crackles, good, and what's their heart sounds? S3 sounds, you're gonna have an extra little sound in there that indicates fluid overload. Okay, so anything lung related, you can remember that because it's left-sided lung. Okay. Um, does it affect? Anyone who's had MI, anyone who has hypertension, that's what we're trying to prevent. Okay, look at this big old floppy left ventricle. Lost its ability to squeeze. Okay. Okay, so talked about what we would see. What are our management of these little patients?
Meds that affect preload, so like diuretics,
Good. Diuretics, we get rid of extra fluid, and that reduces. Reduced preload. Good. Good.
there's also drugs that affect afterload, like ACE inhibitors and angiotensin, if you can't, use ACE inhibitors due to the cough, you can do angiotensin receptor blockers.
Yeah. So we can do ACE. There's going to do ARBs, right? Okay, so what does that mean to reduce afterload? What afterload is? Yeah.
The pressure, the heart fight against the pump blood out, so that'd be like hypertensive.
Right, so if you're hypertensive and your little left ventricle has to push against that to get blood out to the body, we want to reduce that so your heart doesn't have to work so hard. That's how we get this. Over time, your poor ventricle just wears out. Like, I cannot push against that resistance, so we gotta reduce the resistance that the heart has to push against. So we reduce afterload, we reduce preload by getting rid of extra fluid. How do we affect contractility?
Jackson,
Gold star, good job. Hinge, that puts a squeeze on those muscles that are working to be able to optimize contractility. All those things, we're just trying to optimize their whole heart function when it's not working well. Okay. Beta blockers might be used as well. Might be able to put like a left ventricular pump in where it's kind of. It's a machine that the patient has to walk around with and it does the function of the left ventricle, but that's not really a long-term solution. Need heart transplant. I'm getting better, but not so good. Okay. Portable work. Okay, which of the following terms is used to describe the amount of stretch on the myocardium at the end of diastole? There. What do you think? What is that called? The amount of stretch on the myocardium at the end of diastole is also known as preload. It's the volume, it's the stretch. How much volume is sitting in there? Okay? Good. 1 hour after administering IV Lasix to a client with heart failure, a short burst of VTAC appears on the cardiac monitor. Which of the following electrolyte imbalances should the nurse suspect? Aiden, come up and draw me VTAC really quick for people who weren't on that yesterday. Just a quick little, doesn't have to be people. You have to suck through my. It's right there, be attention. If we see something like that, after we give Lasix, what are you gonna do? Pull up their chemistry panel. And look for. Hypokalemia first, then calcium and mag. Okay, but first I'm looking at potassium. But specifically after Lasix, is that a potassium sparing diuretic? It's a weak diuretic, so we're losing potassium. In fact, have you been asked 15 times? Up to this point, probably, what you should check before you give Lasix? Potassium. If you don't, you can throw someone in this, you need deadly rhythm, right? So check your potassium before you give Lasix. Good job. After an anterior wall MI, so an anterior wall heart attack, which of the following problems is indicated by auscultation of crackles in the lungs? Left-sided heart failure, pulmonic valve malfunction, right-sided heart failure, tricuspid valve malfunction. You just told me, left-sided, right? Left-sided heart failure. Good job. A client is receiving spironolactone to treat hypertension. Which of the following instructions should the nurse provide? Eat foods high in potassium. Take daily potassium supplements. Discontinue sodium restrictions. Avoid salt substitutes. Good job, well done. Salt substitutes are just high in potassium. Is spironolactone a loop diuretic? Is it a potassium sparing diuretic? Yes. Professor Brosnan was so happy right now. Tell her how awesome you guys are. Okay, the following classes of medications maximizes cardiac performance in clients with heart failure by increasing ventricular contractility. What do you think? Good job, inotropes. Inotropes is an inotrope. Good job. Okay, let's look at valves. Valves. We're gonna talk about back to that little key. Oh, this is open to anybody, by the way. You can come in here and they're pretty good. Let's look for, look at all these. Bypass surgery, heart attack, heart failure, blood flow, heart valve, prolapse. Let's look at that one guy. Okay, look at this. Here is normal function. Right, here's your little valve opening and closing. That's what you hear when you hear S1 and S2. What are these little guys called? Where's my little A and B people? Right here. Those little fibers that hold the valve in place. Andy, I would be throwing it to you people. Good job. Good job. Cordite, tendinite, right? That's what secures that. So sometimes what this requires, this is normal, but what we're gonna look at next, sometimes it just means like tightening those down a little bit. Okay, so this is normal. This looks like what prolapse looks like. See how it billows back? Kind of, those leaflets are coming back. Okay, so they will take those cordite tendinite and pull them tighter, securing them into the inside of the ventricle. That could be a fix there. Okay, so that's prolapse. Regurg is, look. So a little bit of blood that shouldn't be going back from where it came, it's going back from where it came, right? We don't want that. It's like when you're trying to get on the subway, everybody's going out, you're coming in, right? You get pushed back out. That's regurg. What do you hear when you're listening to your people?
Murmur.
A murmur, right? So tell me again, where are you going to listen? This is so funny. Someone just told me this. Did you guys learn this? Oh, the accelerated students. I asked this question and they're like, apartment 2245. Like, what? I've never learned that. Apartment APTM. Apartment M, I guess. 2, 4, 5. Is that an AP thing? Or you guys just know that? Oh, Dr. B. Apartment 2245, okay, so what does that mean? The aortic valve you can hear on the second intercostal space. Right side. Pulmonic, you're gonna hear second intercostal space. Left sternal side. And then fourth intercostal, tricuspid, fifth intercostal, mitral. Okay, so if you hear a murmur, here. You're gonna say, I hear a murmur or something unusual. Maybe you don't know what it is, but it just does not sound like love dove. Sounds like. You're like, I hear something at the aortic valve. So then the cardiologist can come in and take a listen to that. We can get an echo and actually look at how that valve is functioning to see what's happening. Okay, so there's many things to be listening for, but I just need you to pick up on what's different and where you're hearing it. Okay? Good. Here's that. Okay, this is kind of interesting. So this is the aortic valve. That's the little mitral valve. You see the little chordate tendinite. These little different shapes here. Semi-linear, right? That's it. There's something else. Oh, okay, look at that. So cool. Okay, this is normal. Ready? The nose. Look at that. Looks like Hogwarts hat, doesn't it? So ears. Like wrinkly and stuff, right? So narrow valve. So stenosis, it just means a narrowing. And in this case, it's a stiffening as well. Okay, so the poor little valve can't open and close like we need it to. And so the heart has to push against that. So that also can lead to CHF. Valve issues can cause that. Let's look at the aortic valve. Okay, aortic valve. This looks like a little bird beak to me. Okay, so that's normal. Oh, it's okay. Come on. Let's look at that little guy. Ew. Stiff. Can't close all the way. Thickened. Not good. Okay, so what do we do for people who have valve issues? Here's your quiz. Okay. What do we do? Oh. Okay, I'll go back to that question. A murmur is heard at the second left intercostal space along the sternal border. What valve is this? Come on. Okay. Okay, so we can put in a mechanical valve. We can put in a porcine valve, like a big valve. Or we can try to repair it. All right, but this person has just had a mechanical heart valve. If you are standing next to someone who has a mechanical heart valve, sometimes you can hear it. I wonder how that feels like to them. They just get used to that. It's like living by the airport, you get used to the planes going overhead. You'll hear like this little as it opens and closes, so like a little ticking in your heart. Which may be therapeutic. I don't know. Or it could drive you crazy. I'm not sure. Which of the following statements by the client indicates understanding of the teaching? I'll be glad to get back to my usual exercise routine right away. I will talk to my dentist about no longer needing antibiotics prior to dental procedures. I will have my prothrombin time checked on a regular basis. I will continue to limit my intake of potassium-rich foods. What do we think? 2, 3, or 4. Oh, look how smart you guys are. I will have my prothrombin time checked on a regular basis because
We need anticoagulation.
lifelong anticoagulation, because wherever that mechanical valve sits, all our platelets want to attack that as a foreign thing. Well, they will accumulate there. right? So we have to be on like Plavix or Eliquis or something like that, Coumadin perhaps. Coumadin, you have to get your levels checked quite a bit. Limit. You're on anticoagulation. What are we limiting? Not limiting, you just wanna keep consistent with the intake of what kind of food.
But
Vitamin K. This is a point of clarification, because it seems to come up, but I need to make sure it's clear. Is potassium and vitamin K the same thing? They are two separate, very different things. Okay, good. What about this? Antibiotics prior to dental procedures. Anyone with any sort of valve issue, particularly a mechanical valve, should have prophylactic antibiotics before any dental procedures. Dental procedures are like classic for having pathogens enter into the bloodstream. And guess where they'll go? Right to that foreign little thing that's in their heart and seed there. So that's what endocarditis is, when we get an infection sitting on a valve or on the inside of the heart. We don't want that, so they take prophylactic antibiotics. So that's wrong. They will continue to take antibiotics before dental procedures. Okay, let's go. Bum, bum, bum. Where are we? Vascular disorders. Oh my gosh. Okay, hypertension. Tell me. Silent killer. Why do we call it that? No symptoms. People don't know it. If I check your blood pressure right now, well, you'd probably be like 90 or 50. Tired. But people can't feel when their blood pressure is high. So it's a silent killer. What are we trying to keep it under? We say 120 over 80 is normal. We used to say hypertension was 140 over 90. But now we're actually hypertensive at what? Pre-hypertensive is 120 to 130. Hypertensive is 130 to 139, right? And diastolic, I should know that. I don't really know that, but we want it definitely below 80, right? Used to be 90. Now it's closer to 80. Okay, so look at those classifications. We're going to use antihypertensives to treat that. Peripheral arterial disease, tell me about that. Peripheral arterial disease and peripheral venous disease looks different. Yeah.
with arterial disease, there's a problem where your arteries can't, your veins are probably working fine, your arteries can't infuse down like your lower extremities, so that's when, because there's no oxygen in the blood, they lose their hair and the skin is like really shiny.
Yes.
And like the ulcers have really well defined borders, they're dry, and it hurts to raise your legs, because then the arteries have to push harder to get out, but with venous raising, and there's no swelling, they're like, yeah, but for venous insufficiency, there are swelling. And the ulcers are really like gross, that's not like medical.
Perhaps,
but, like,
yes, yeah,
weepy
Yeah,
and
good.
like not well defined borders.
good.
And they can have like the discoloration, but there wouldn't be, there's no like blood flow, although it's venous stasis.
Venous stasis, that's right. So I'm sure you have seen people with venous stasis. They kind of have, like, can look like edema, but it's kind of a brownish discoloration. It actually helps to put their legs up to help with that venous return and to reduce that swelling. But peripheral arterial disease, no, if you put it up, their feet turn white and they have pain because it's just not getting perfusion. They also may say, like, when they're walking, that they get like Charlie horses in their calves. You know, like cramping in their calves. That's intermittent claudication. That is a key indication that we have reduced perfusion to that area. If someone has CAD, I would bet money, a lot of money, that they have PAD. So it often goes hand in hand, okay? So everything that Haley just said, I need you to know, because I'm gonna ask you how to distinguish between venous and arterial, okay? Carotid artery disease. Tell me about that. Talking about the carotids here, these big old vessels that perfuse to your nagi, so important. We can get accumulation in there as well. Remember when I told you about my dad? He had carotid endarterectomy, where they open up here and pull out that plaque. But oops, they forgot to check his coags. Oops, he probably almost died on the table. I'm sure they were probably standing on his carotid to get him to stop bleeding. For the love, check your coags before you start cutting into someone's carotids, right? Stroke is a huge risk with this, because you're cutting off blood flow, right? As you repair that. Bleeding obviously is going to be a risk. So afterwards, keeping them in neutral alignment is important. What do you think happens? You know, what's sitting right in that carotid is our little chemoreceptors and baroreceptors. So let's say I've had a narrowed passageway. Blood is barely getting through whatever's sitting in there, that cholesterol that's sitting in there. And now I've taken that out. So all of a sudden it feels like, whoa, we have a lot of volume. Do we actually have an increase in volume? No, but the baroreceptors are like, whoa. Because you just have this increased blood flow after you remove that blockage. So hypotension is a real thing. Okay, so be watching out for that. Head alignment, maintaining good blood pressure control is important. Bleeding would be a concern for these people. And taking on home, DVT, Virchow's triad. We love like our Bex triad, Virchow's triad, like anything like that. You gotta know that because it's real. You'll see it on the NCLEX. We have decreased flow, we have damage, and then we have increased coagulability. That is what Virchow's triad is, and that's how we get DVTs. That's what we're trying to prevent when we put TEDs and SCDs on. We're giving Lovenox or subQ heparin, getting people up and moving. Lastly, oh my gosh, is PAD. So in lab, you're gonna check ankle brachial index. What does this indicate? The presence of peripheral arterial disease. Chalese is talking to us about. So you check my systolic blood pressure in my ankle. You check my systolic blood pressure in my arm. You divide those, and if it is, say yes, less than
0.9.
less than 0.9, that indicates positive PAD. Which is not a positive thing, but good to know for us. Okay, that means they have reduced blood flow to their extremities, which means they probably have reduced blood flow to their coronary arteries. Okay, we'll open up that little quiz. Please complete it before Monday. Now for the little Google Doc before. Awesome. Thank you, thank you.
Good, how are you?
And then I need to edit it or.
Thanks, man.
It was a really because I was like, I came into it and I was kind of like nervous, but I never